editor publisher of Double Helical. As you know, this Double Helical is a leading national health magazine and being circulated from Delhi NCR region. I really warm welcome to all of you. Today we have the webinar on the topic Mucormycosis black fungus. Is it an entity to worry about? It's a topic of the today webinar, and I'm welcome to all of my eminent speakers and eminent personalities all over the India. Today, as you know that there are 5,000 plus black fungus cases all over India. This is not only black, this is white and yellow right now. Now, all of the doctors who invited today and he joined today, they will highlight how to eliminate it and how to go in the right direction to curb this epidemic along with the corona COVID-19. Now I request to Dr. A.K. Agarwal. He is the senior doctor and he is the ex-additional Director General of Health Service, Government of India, Professor of Excellence, and right now he is the Medical Advisor and Innovation, Apollo Group of Hospital. Warm welcome to Dr. Agarwal. Please moderate of the today webinar.
Thank you, Tiwari-ji. First of all, I like to welcome all my colleagues who have joined today to deliberate on the topic which has become very relevant in this scenario when we were fighting with COVID. And after the COVID, this is something which is very challenging, and we, the medical professionals, are just thinking how to come out of it. Of course, first of all, I would like to say thanks to Double Helical magazine, with Chief Editor Shri Amresh Tiwari-ji for organizing such a wonderful webinar. And obviously, we will start with our one by one different expert, which I'll be requesting them. The topic is mucormycosis. Mucormycosis, you know, I am basically an ENT doctor. And for an ENT doctor, if I talk about mucormycosis, there is nothing new. Ever since we started our career as ENT, and with now after 50 years, I would like to say mucormycosis we have been dealing right from the beginning. We talk about white fungus, yellow fungus. Dr. Sharma, you know, we are dealing with Candida albicans in the ear, or at many places, Aspergillus niger. So for fungus, we are well tuned to. Let me go back to my young days when mucormycosis was a big challenge. It is a big challenge. And the maximum reports of mucormycosis, to the best of my knowledge, came for certain geographical area like Punjab. PGI Chandigarh was one place which has published maximum paper on mucormycosis. And then certain eastern areas where the certain fungus infections were very, very dominant. And if all of you try to recollect your MBBS days, if you try, you remember rhinosporosis. The rhinosporosis is the strawberry-like little tumor in the nose, which has got strawberry appearance, and this is because of the rhinosporosis, which is very commonly found in Odisha, in certain lakes and ponds. So what I want to say is that there was fungus right from the beginning. There was some geographical distribution, but suddenly after the second wave of COVID, we found that this occasional thing, a rare thing, has come up in a way that people started calling it a pandemic, or I do not know what sort of words have been used, that it has come in a big way. So it becomes a challenge. And challenge in a way because Number one, the person has suffered with COVID. He has already spent 2 weeks in hospital, 10 days in hospital, more than 2 weeks in hospital. And suddenly he comes with certain complaints, and then, my dear, you are having something called mucormycosis, which is bad. So obviously it enhances the worry and the stress factor of the patient in such a way. Certain cases are so advanced it becomes fatal. I think, like, with this brief introduction, I'd like to invite my colleague, Dr. M. C. Mishra, the ex-director AIMS of New Delhi, who had been Vice Chancellor of Mahatma Gandhi University after he finished his term from AIMS, and he is the person who started the trauma center of India, Jayaprakash Trauma Centers. And I always say, Dr. Mishra, you have brought ATLS to India, a life-saving step, and you have taught so many thousand students. So with this little introduction, I would like to invite and request you, Dr. Mishra, we were treating COVID. We treated COVID in first wave. We were treating COVID in second wave. What happened, where it happened, that now we are facing black fungus, mucormycosis? Your observations. I will like you to request if you want to have some slides or you will like to speak extempore. Please.
Thank you, Professor Agarwal, and Dr. Amresh ji for organizing this panel discussion on such a important topic, which Professor Agarwal very aptly summarized, a disease which was so rare, and today many states have declared it as an epidemic, rightly so for various reasons, and it was again, as we were taken off guard for the second wave of infections, this has even further surprised all of us, what is happening with mucormycosis. Naturally, as the ENT specialist, Professor Agarwal would deal with it, but as a general surgeon, we would come across such a case very sporadically, very occasionally, rarely. I remember only one case where somebody had a pacemaker on his chest wall and he developed mucormycosis around that, and we debrided it, and then we gave amphotericin B, and he responded to that, but then he went to Uttarakhand, and I think later on he succumbed. This patient succumbed to his illness. But this is something which we never anticipated, that this is of some kind of disease which will become so common, and we will see thousands of cases. This is totally unexpected, a surge of cases. And what basically we are seeing the differences within the first wave and second wave. First of all, of course, the exponential number of COVID illness patients has suddenly surged, because we had maximum 98,000 one single day infections in the first wave in September last year. This year we got 4 lakhs and plus cases, infected individuals reported. And the most surprising part was that these patients recovered from COVID and went home and then returned with these symptoms. And then when it was investigated, they were found to have suffering from mucormycosis. We all know the certain age groups, certain disease-specific groups where our immunity is down to acquire these opportunistic, so-called opportunistic pathogens like fungi, like in patients who have undergone kidney transplant and on immunosuppressive therapy. Also, they receive steroids sometimes for rejection, etc. Then also those who are on some form of cancer treatment by way of chemotherapy, radiotherapy. These individuals will also carry the risk. Bone marrow transplant patients and patients who were hospitalized in critical care units. Actually, these are the groups where the antifungal medication becomes routine part of the protocol in the ICUs. And even in, if we remember from 2020, from Gangaram Hospital, there were reports of 2 or 3 mucormycosis patients. This was the only report we got, and there was some talk, but it never came to this proportion what we are witnessing during this second wave of infection. So how things have been different in this? Number one, the large number of patients and significant number of patients also developing severe COVID sequelae in the form of pneumonia, the lung inflammation, getting admitted to hospitals in ICUs. But these are the patients who have not necessarily been admitted to ICU. They have been treated at home. Many of them have not received even oxygen. But one, naturally, the risk factor stands out is the uncontrolled diabetes. That is number one. But there have been a significant percentage of patients who are non-diabetic also. But one single important risk factor which we are thinking could be the steroid misuse, or should we say improper use in large doses which may not have been required from the first week itself of the COVID illness, which is totally inappropriate form of therapy. And then the diabetes, which was not well controlled, again became further compromised in the control. And then these patients came back, they secluded themselves in the home environment. So that is where, and I was listening to one person from Karnataka who has in Karnataka dealt with large number of COVID patients, and he says this mutant virus particularly has been associated with it, but we don't have any genomic sequencing on these patients. But I think it's a good area to look at what is the source. In the beginning, I thought maybe industrial oxygen has been used. The cylinders which were makeshift like nitrous oxide cylinders and other cylinders were also put to use as an oxygen cylinder. But then I was told that industrial oxygen is also very, very even better than medical grade oxygen. So it is unlikely. Then, of course, another risk factor was pointed out that this humidify because most of the oxygen is humidified before it is given. So the water which is being used or for this might have had fungus. But as I mentioned, not everyone who got oxygen developed this. There are patients who without oxygen also. But one thing is common, that they all had COVID. They all had recovered from COVID. Good number of them received steroids, and that too in high doses of steroids for a more than 10 days duration. And many of them were treated at home. Like from Gangaram, when Dr. Rana and myself on a program day before, he said 59 patients they have, and out of that 35 only had diabetes, 13 did not have any diabetes. We don't know yet the age group, so they are collecting their data right now. So that is something which again was very worrying. Then even younger patients, 15-year-old boy also got mucormycosis, and it is largely the rhino-orbitocerebral mucormycosis. We all know that these pathogens are present in the air, in the environment, whether it's virus, bacteria, or fungi, and we inhale through our nasal passages, air passages. And those who have sinus problem would be definitely at a higher risk of developing this problem, because these are not aerated, these sinuses, and there is a nasal blockade and all, and they will develop these symptoms. And I was discussing with one ENT surgeon from Mahatma Gandhi Hospital where I was in Jaipur. He said, we have currently about 30 patients, 20 of them have been operated. 4 out of 20, they had resorted to the enucleation or debridement of the eyeball. and also the cerebral component of it. And we all know irrespective of what, even if they get all treatment, amphotericin B, and somebody told me just an hour ago that there is a patient in GTB hospital, it's an NTPC employee, and he has undergone surgery, he has again enucleation of the eye, but he has not got amphotericin B for 48 hours since he has been admitted because it's not available. So this is the kind of scenario we are in. We are still at it, that why it has happened to so many people, non-diabetic, diabetic, with risk factors. But one naturally common factor is that none of the people who did not have COVID have developed this. It is COVID definitely has some correlation, whether COVID itself reduces so much immunity in some people and not. In Gangaram also, he said only 3 patients have returned who were discharged from Gangaram. Rest of them have come from outside. So this same thing with AIMS. I was just discussing about half an hour ago with a critical care specialist in AIMS Trauma Center. They also have almost 35 patients currently, and most of them have been operated. So you can imagine the invasive mucormycosis, what it has been led to, and that is the worrying part of it, that once we all know that what is the prognosis if they develop the rhino orbitocerebral mucormycosis. Despite best of treatment, mortality is as high as 96%. So I think that is where we still do not know what has led to this problem, but naturally these factors of COVID, steroids, and also the way people have maintained their hygiene. I think nasopharyngeal hygiene is something to do with it. When they are at home, maybe they have secluded themselves, not ventilated rooms, etc. And we don't know the living conditions, what kind of people these were, and any other factor. But I think this ENT surgeon from Bengaluru, he was saying the mutant virus has also something to do with it. So with this in brief outline what I have understood, but this is something is very worrying for all of us. And amphotericin B, which is so crucial for the recovery of these patients, is in short supply. 9,000 patients all across India. Hardly we were seeing one patient in a year. Even I think Dr. Agarwal can vouch and others that how many patients we see in a year of mucormycosis. And then naturally when mucormycosis can happen, Candida can happen, Aspergillus can happen, and any other fungal infection can also, because these are all opportunistic organisms. So I think that is where we are. What I thought that maybe ICMR must have made some task force on it to get to the bottom of this problem, because the data definitely needs to be looked at very carefully to get to the bottom of this issue, even if we are not able to save many lives. Thank you, sir.
Thank you, Professor Mishra, for highlighting all the possible factors, because perhaps we don't have a literature of the past. So much I've experienced, what we are experiencing in last couple of months, we never thought that any time in centuries the things has happened. So this is very unusual circumstances. Before I start further, let me also mention that today's this particular webinar is also attended by my colleague Dr. Mahesh Verma, the Vice Chancellor of IP University and the person who is responsible for bringing up the best dental college of the country, Paranasal Dental College.
Thank you,
and he has so kindly offered himself to give us the brief and summary of our this particular discussion at the end of the topic when we finish. Thank you, Mahesh, for giving us this wonderful opportunity.
Thank you, sir.
And of course, we'll come to you as a dental colleague of ours, the dental section. I think I would like to proceed since my colleague, Dr. Padma Srivastav, has to leave early, if you allow me. Padma is head of neurology in AIMS, and she is there. Perhaps she is responsible for so many initiatives in AIMS, including the areas of epilepsy, and there are so many. Let's not talk now. Dr. Padma, what what is your opinion regarding, as we know that it comes to rhino and then becomes orbito, sinus, and then ultimately the area of brain, and then it involves brain, and the moment it involves brain, of course, it's life-threatening. What is your stake on this particular advanced status of disease?
Sir, sorry to intervene
Yes.
for a while. We welcome to Dr. Girdhir Gyani. He is the Director General Association of Healthcare Providers of India.
Dr. Gyani Sahab. Thank you, sir. Welcome, welcome.
Namaskar.
Yes, namaskar. At the end of the discussion, we will appreciate your comment. Over to you, Padma.
Thank you, sir. Thank you, sir. And thank you, Mr. Tiwari, for the kind invite. And it is an honor to be on this very august panel. I see my teachers, Professor Mishra. It's an honor to share the same platform as he is, and several of the seniors out here. And thank you once again. Now, when you're looking at, there are some very interesting things that had come up in the discussion as to why second wave we have this deluge of cases of mucormycosis. I think one thing we need to actually to the public also that don't label them, don't color code them into black and white and yellow, and and tomorrow we have a rainbow, and we do have a rainbow fungus by
Absolutely correct.
the way. So instead of saying that, because the black, I want to say this, sir, is because we've had some questions coming from public who said that I've seen this black moles which are there, and when I open my fridge, is that a black fungus? So I think we send out a wrong message, and we know that mucormycosis is black because of its angioinvasive nature and producing necrosis of the tissue, which turns black. Said that, now beside the deluge of cases which have been there, now I want to bring out some points that epidemiologically we've always been a land of where we did always see more cases of mucormycosis as compared to the rest of the world. And when the prevalence was said to be something like, so there's a conflict.
तिवारी जी, आप अपने को म्यूट कीजिए. तिवारी जी, अपने को म्यूट कीजिए. Thank you. Please,
so yeah, so the earlier prevalence, some of the very, very good epidemiological data. In fact, 2019 also we've had a very good study coming from India, where they compared not just the cases across India over the last 5 years, they've also compared with the cases from the rest of the world. Say, for example, when from part of the West Asia, where it was 0.43 per 100,000, we had cases about 1.4 per 1,000. So we really did have more cases, and these sort of have also increased in the last decade or so across the world. But most of our ROCAMs have always been, incriminated in diabetics, and that the kind of species, the commonest is Rhizopus, and the most malignant of all the species of Mucorales is a Cunninghams. So that's the most malignant of it. But the commonest causing ROCAM is also the Rhizopus species. Now, when we've seen, Professor Mishra has already sort of given you idea about the breakup of the mucormycosis, which is happening over the last couple of weeks, I must say. And as he said, nearly 9,000 cases and counting. We've also he's spoken to the trauma center and other COVID areas and AIMS. He's also got the data, which is very similar to what has been the public domain from Indore, where 210 cases were analyzed, and some published reports from, in fact, one sent for publication from the western part of India regarding ROCAM by the neurology group there. So out of the mucormycosis, the commonest presentation still remains ROCAM, which was there earlier and which is there in this wave as well. So this is, in fact, it has been seen to be more than 60% of all cases to be ROCAM. It is rhino orbital or rhino orbital and cerebral, as compared to whether it's pulmonary or gastrointestinal or renal, which have been just stray case reports. Said that little about ROCAM as such. So when the angio-invasive nature of the mucor is said to either spread by a direct invasion from the sinuses per se, especially the ethmoid sinus, and as ENT, sir, you would know better. But I think the more important thing also has been what are now, there's a new term called Mucormycosis. This is essentially the endothelium being invaded by the hyphae, and you are actually getting the mucor as embolus, and it is traveling through the vessels. So you don't get a sinus, you don't get an orbit, and you get directly a CNS infection. So that is the isolated cerebral mucormycosis. And there has been 2 case reports which have already been now reported in this second wave of an isolated cerebral mucormycosis, which is and the area of where it involves is basal ganglia. Classically, the basal ganglia is the area of the brain which seems to have predilection for mucormycosis, and they've reported 2 cases wherein there was just this granuloma formation. Said that when there is a granuloma formation, they probably do a little better as compared to an abscess per se, because a granuloma implicates that there is some kind of a host difference mechanism, whereas an abscess means that they don't. So, but most commonly though, what we have is angio-invasion and a direct penetration, destruction of the skeletal muscular system, and then going in as a direct invasive proportion. So they involve the cavernous sinus, and through the basic involvement of the blood vessels, they cause hemorrhagic infarctions. And when you have the whole brain where there is a parenchymal hyphal involvement, it is invariably 100% fatal. Even before that, when you have a cerebral involvement, the mortality is deemed to be at least 75 to 80%, even in the best of circumstances, and an extremely early involvement in terms of multi-speciality surgical debridement of the tissue and a very early institution of an antifungal treatment would probably bring it down to about 30 to 40% mortality when there is a cerebral mucormycosis. So far, apparently in the second wave as such, at least the ones which are in public domain, they're not talking about too much of a mortality, but I'm not too sure that we have the correct figures yet. And so besides the mortality, what about the morbidity of the ROCAM that we see? When you have it, either the presentation is in terms of several shades of altered sensorium going on to more severe encephalopathy and coma. You may have focal deficits, you may have seizures, but the presentation may come up with not just an isolated and new onset headaches, it may go on to very, very severe headache, bursting headache, and then of course the commonest presentations would be encephalopathy, seizures, and focal neurological deficits. In that order, in terms of, and then varying the variety of deficits will depend upon what area of the brain is involved. The commonest areas, as I said, is cavernous sinus, and then when you have a parenchymal involvement or isolated mucor, it is a basal ganglia either one side, and quickly it has a capacity to go on to the opposite side. Now that said about the ROCAM per se, we are still trying to analyze the spectrum of ROCAM, which is also being presented in the second wave right now. But I guess as far as ROCAM is concerned, whether it has been the second wave, incidentally, interestingly, there's been comparison even to the first wave, where the numbers are far few, but whether it is first wave or second wave, the spectrum has always been predominantly ROCAM, followed by a pure, the rhino or rhino orbital. So ROCAM has always remained as one of the worst cases, as well as the highest percentage of presentation of mucormycosis. Quickly, sir, when you were asking about why are we seeing this surge, and as you very rightly said, and as Professor Mishra said, the low-hanging fruits of hypothesis, which is probably acceptable to the majority, and which is also low-hanging because we also have the algorithm of trying to intervene and prevent that, would always be that, oh, look, you are misusing steroids, and we have this, we have a diabetic epidemic. We have the dubious distinction of being the diabetes capital of the world. So we have the maximum number of diabetics in the nation and maximum number of diabetics in Delhi. Therefore, we have so much more happening. And COVID itself is a low immune problem. There's a lymphopenia. So there is the whole immune response nosedive. So we are prone to all sorts of infection. And now we also know that it involves a pancreatic islet cell, so that itself causes hyperglycemia, compounded by the fact that there's a whole host of people who never know that they're diabetic and they don't care that they're diabetic. We didn't care about taking care of the blood sugars. And then there is this over-the-counter use of steroids. And just yesterday in the evening, in fact, I got an SMS from a very educated person who wanted to go somewhere else, and they said that what is the list of medications I should take with me on this. So I said I suggested the same thing, or take paracetamol, take something for allergy or loose motions. He said, how about steroids? So I said, why do you want steroids? He said, no, steroids are the Ramban. I mean, I must take some steroids. So therefore, now that's been the response, I think, across the country, at least, that steroids is the only Ramban that we have. So if there's anything at all, let me just start off steroids straight away at home, even before I contact anybody. So that's been there, and steroids were meted out like peppermints over the counter, even without prescription. So that's there. But besides all this, I think, sir, there have been certain local issues. As Professor Mishra said, we certainly need more genome sequencing to understand this virus strain per se. I'm not getting into the humidifier or the use of distilled water not being there, and the tubes and the hygiene part of it, or the oxygen or whatever. But I think some local practices, like there's been a rampant use of steam inhalations. And there's been some, talk about micro burns in the nasal mucosa because of this excessive steaming. Now, the steaming was being performed again locally, especially in home isolation, that part of it, because whenever there is a low immunity and you have a breach in the mucosa, that's one of the reasons where these the saprophytic fungi, which are all around us, can get in. And also the use of masks. There was one which came into public domain where they actually grew these mucorales on the mask front. And this was a mask which was sort of soiled and was being used repeatedly. So there was also an advisory given by some of our medical practitioners as to how to use this mask and how to hang it on a nail and when to use it, and small things which are probably very, very important. So the hygiene part of it probably also involved the mask usage, the steam, and then this hypothesis of zinc and all. I'm not getting into it because I have no evidence to talk about that. But all this has been put forward. So there's a host of information that we still need, and active research is required. And the last part of it, of course, is the treatment. The treatment is no different whether it is COVID or non-COVID. It remains the same. It's a very aggressive management. The only constraint that we have now is an early diagnosis, where a lot of these getting the KOH mounts by a swab is not turning out to be positive. So a high amount of you should red flag it, and there should be actually go beyond trying to use just diagnosis just by a KOH mount, I think. And every time we can't take a biopsy, so there is a PCR technique which is also being developed. So maybe blood PCR may also help, and there are these NGS sequences which are also being developed, at least in cerebral mucormycosis, used in the CSF sample. So these are all the things which probably would also be required. So thank you.
Thank you, Professor Padma.
Sir, sorry to intervene.
Yes.
Welcome to Dr. Vijay Agarwal, sir. He is a president, CAHO, and Dr. Sunila Garsi has been joined. Welcome.
Great. Sunila, Vijay, welcome to both of you.
Thank you.
To continue with Professor Padma, thank you very much. बहुत अच्छा तुमने कहा, रामबाण जो पब्लिक में कंसेप्ट है कि रामबाण हमने ले लिया, हमको कुछ नहीं होगा. The diabetes, the management of diabetes. There are many things which we have to think, consider. And that is why we have invited one of our colleagues, General L.R. Sharma, who had served in Indian Army as major journal, and I salute every colleague of mine, but I salute more to my Indian Army colleague always, and who had been serving Apollo Delhi in capacity of administrator as well as the senior consultant. General L.R. Sharma,
Thank you, sir.
we would like to have your opinion as physician, because you have to, what ENT surgeon thinks will be different.
Thank
right?
you, sir, and thank you so much. Thank you so much, Dr. Agarwal, sir. And I must thank
we have to highlight your opinion as physician.
Sir, the Mr. Amrish Tiwari for giving me this invite and to be present and share the dais with so much eminent personalities. I'm an internal medicine specialist and I've been dealing with COVID from the beginning and must have crossed my 1,000 figure treating these COVID patients. There have been a lot of discussion going around in the whole country, and this one seminar is part of it, that why this has happened. Now, since I'll be talking mostly on diabetes, I'll constrain myself to this diabetes only and will not go into the other controversial topics. But as
diabetes is very important. We must know.
Gangaram
said that partially they were diabetic, partially they were not.
So as we all know from the beginning that ours is, and Dr. Padma just referred to it, that ours is a diabetic capital of the world. And if you look at the number of cases which has happened this time, for the second wave, it has been astronomical, exponential increase in the number of cases which occurred. And even if you look at the data, which the other day I think there was a report that out of the 28 cases, 95% were diabetes, even in Gangaram Hospital. And we in India, as we know, everybody is not screened for diabetes. So even many patients who were given steroids probably had underlying either borderline diabetes or they were pre-diabetics. And we all know that even COVID per se increases the blood sugar. Therefore, in my opinion, this increase in number of cases has been probably contributed by irrational and very large doses of steroids, which were started very early because the fear factor was so much in the public that everybody wanted to have a steroid. In fact, most of my patients would ask, Doctor, you have not given steroids. So I think that is one of the very major factors which has contributed to this this exponential rise in the number of mucormycosis cases among us, these COVID-treated patients. But the management of diabetes has taken a second has gone on to the back burner in all the COVID cases, especially those who are treating at home. Nobody gives that attention to strict control of diabetes. And we all know that this mucor or mucorales has been occurring earlier also in immune compromised individuals, and diabetes is one condition which affects almost all systems, and hyperglycemia per se is supposed to interfere with the phagocytic system of the our neutrophils. So if you look at who get as already told by Dr. Padma and Dr. Mishra, this fungus is ubiquitous. It is in the environment. It's an environmental fungi. It is available everywhere. Why is only a particular set of patients get it? Why everyone doesn't get it? So it is only the weak people who are with a weakened immune system or immunocompromised system who get this disease. Me and you, all those of us who are healthy, will not get it. There are exceptions, of course. Like a cutaneous mucormycosis can occur after the implantation in a wound, surgical wound, or post-surgical through contamination of linens and otherwise. But that can occur in immunocompetent individuals. But otherwise, majority of the cases would have occurred in immunocompromised individuals. And diabetes is one state which compromises your immune system. Hyperglycemia is known to have a negative effect on the phagocytic activity of neutrophils. So if you look at the pathogenesis of mucormycosis, The diabetics have hyperglycemia. People with neutropenia, especially those who are on chemotherapy or who have persistent neutropenia, or cancer patients, they are the ones where the phagocytic activity of the neutrophils is disturbed, and that is where the fungus is able to grow and multiply. So it is quite possible, whether we look at the human cell, stem cell transplant patients, whether you have solid organ transplant patients, whether you have liver transplant or even chronic liver disease patients, and HIV and other chronic kidney disease, for example. All these patients, the incidence of mucormycosis overall, if you look at it, is majority of them have some sort of immunocompromised system. Now, whether COVID, this strain or COVID per se, is also contributing in some way or the other, that is a point for research. And I think the government and the ICMR probably are putting their mind onto it. And as Dr. Padma suggested, probably they will do a gene sequencing, that they'll try to find out the factor, whether it really contributes towards creating hyperglycemia and creating a conducive environment for the mucor to multiply. If you look at the number of cases, almost all, rest, I think that would be a negligible number which has gone into a pulmonary mucormycosis. Everything is concentrated on the rhino orbital and cerebral. So rhino orbital cerebral, almost 98 to more than 98% are these rhino orbitocerebral or rhino cerebral or rhino orbital. So why, how come? If there were many other factors, like somebody was trying to put oxygen, somebody was trying to put something else, then the pulmonary would have also got, the same compromised individual would have got a pulmonary mucormycosis. So how come it only, there's a predilection in the sinuses alone? So it's quite possible that those patients of COVID who had recovered either were pre-diabetic, majority of them are diabetic. We know that almost 95% individuals are diabetic, and therefore diabetes remains one of the major predisposing factor towards developing mucormycosis. I am not saying that there are not other factors. The COVID per se, you put COVID, you put diabetes, pre-diabetics, or those who have not been screened and they develop diabetes, and you start treating them at home with steroids, blood sugar goes haywire, they do not even know, nobody checks it, not even part of investigation it is there. Normally we do it, HbA1c for every patient of COVID. That is what I have been doing it. For every patient of COVID, we go and do HbA1c. So these patients, the COVID per se probably also produces hyperglycemia. And if you look at it, what I have seen, some of the individuals have very high ferritin levels, very high. Is there some mechanism that the COVID is producing, releasing free iron into the system? And we all know, since that time, if you look at the pathogenesis of mucormycosis, they grow. It is part of their growth factor. They nurture very well in the serum and in the tissues. If the iron is released there, their multiplication and the virulence becomes much more. So therefore, is there some mechanism by which that there is more iron released, free iron released into the system by COVID, which again encourages the mucormycosis to grow? If you look at it, if you remember our teaching, the patients of diabetic ketoacidosis were also supposed to be more prone to this kind of infection. Again, what does the acidosis probably, somehow again releases the free iron from the sequestering proteins in the blood in these cases of and this release of iron during diabetic ketoacidosis again favors the growth of mucormycosis. And because it is in the environment everywhere, so the people who are susceptible will get it. Now, what other mechanism probably is involved? As Dr. Padma has already said, once these spores are available, they get lodged into the nostrils, they start multiplying, change into hyphae, and they invade the vessels. And once you invade the vessels, they will start producing thrombosis there. And once you produce the thrombosis, then naturally this blood supply to the distal tissue becomes 0, the tissue starts necrosing, and after initial redness, there is a black, almost like gangrene-like. So that is why you get that black eschar, and this keeps occurring and it keeps spreading, and gradually you start eating the bone, and then you go into the orbits, and then gradually going through the sinuses, ethmoid, and then into the brain to the cerebral part of which of course has already been dealt with very elaborately by Dr. Padma. So I think this whole so-called epidemic now, if you look at the cases of almost, I think we have had more than 2 crore cases of COVID in India. And what is the number of this? Maybe it is crossing 9,000 to 10,000. A couple of days back, it was 7,000 cases of mucormycosis. I think it certainly is an alarming number, but whether to call it really an epidemic, I really don't know. That is again, the different states are taking their different view. They have their own reasons to declare it as an epidemic. But if you look at the number, then the number is far too many cases occurring every day. So therefore, if you look at that percentage of total number of COVID cases and percentage of mucormycosis occurring, I don't think it is that percentage probably would remain same if we compare earlier also. The India has earlier also been the major part of this paper which recently been I think out by Dr. Shashank Joshi and Dr. I think Amnish Mittal. They had analyzed about out of the 101 publications till 2012, 81 publications were from India. So we already had so much incidence of mucormycosis in this country. So maybe the geographical places wherever, as Dr. Agarwal was referring to and alluding to, and even Dr. Mishra alluded to certain other factors. There could be many other factors which probably has contributed towards this. Whether somebody was saying in Indian context, the way the media had told everything, you isolate yourself, you quarantine. So people have quarantined into small places. Depending upon which type of residential premises they had, those who quarantined themselves in small rooms, whether they were humidity, what was the level of humidity there, whether they were using AC or not, and whether how much was their personal hygiene, and whether the mask they were using could have. I mean, after all, once the mask gets wet, it's a very good environment for the mucorales to grow. So it's quite possible there could be other factors. Now, but the other day there was every day there are so many opinions people are giving. There are a lot of gyan on WhatsApp and even otherwise. In the newspaper also there has been come that looking at the quality control in our country for any of the manufacturing processes, there has been of late, because there was shortage of everything, including medicine and including the nasal swabs. The nasal swabs where you are trying to put the swab and trying to take the sample. Now these swabs are supposed to be sterile. So were they really sterile? Is there a quality control check somewhere at some place by the government of India? I really do not know. The other day there was a video being I think viral, that there were children who were sitting on the ground in a very filthy area and trying to make these nasal swabs for taking RT-PCR test. So this could be contaminated if these swabs were not really properly sterilized. That could also be one of the contributing factors towards, because they will easily get lodged into the nostrils of the individuals. Now, we also know that this mucormycosis can also occur in immunocompetent individuals. But if you look at the immunocompetent individuals where it occurs, the numbers are very negligible. Now, where it occurs is probably the contaminated wounds. The cutaneous mucormycosis is known to occur in competent individuals, but that is again by contamination. The contamination could occur from the soil. In surgical cases, I have seen one case where probably linen was responsible for contamination and the surgical wound had mucormycosis. So there could be multiple factors, but the pathogenesis by and large, if you look at the overwhelming evidence would be that COVID per se probably is producing some damage even to beta cells, which again is an area for investigations and research. And the holy trinity, the so-called dialogue to be taken from somebody else, the holy trinity of COVID-19, probably directly responsible to some extent or indirectly creating hyperglycemia, probably even invading beta cells, and uncontrolled diabetes. In most of the Indian circumstances, we really are, even our educated people are not bothered to control their diabetes. And the third factor, very, very important factor, is steroid use. Believe you me, I have seen prescriptions with three steroids at the same time. And look, our so-called doctors, even qualified ones, and the scare was so much that start steroids. People have been starting steroids from day 1, day 2, day 3. It is we've been taught in the school, we were taught in initially MBBS that viral illness, if you start steroids in the beginning, is going to create more trouble to you. Therefore, steroids should not be given in viral illness. COVID being such a disease where we had nothing to else, somehow we learned that steroids are of use, but then this has been misused so profoundly in this second wave. And to my mind, instead of putting, I think, the blame on the industrial oxygen or the other oxygen, you should have a pulmonary mucormycosis, you should have systemic mucormycosis, but it does not. There is a predilection for the rhinocerebral. So therefore, to my mind, the overwhelming factors have been steroid misuse or irrational use. I would not call misuse, but there has been misuse also. Every quack has been treating COVID cases. If you see, there are people who were caught who was running a 100-bedded hospital. A quack was running a hospital. So there he was treating people with steroids. And we know how our people give steroids in the form of, magic bullets to treat even prolonged fever. So therefore, the irrational and large doses of steroids in a population predominantly diabetic, or those where screening has not been done, probably they were pre-diabetics, and COVID per se directly contributing towards lowering the immunity of the individual, has given rise to these exponential numbers of COVID in this second wave. And going by the percentage, and if you want to have the statistical data jugglery, then I think if you look at the percentage, probably it will not be more than what it would be when you analyze cases which were occurring during the first wave. But yes, I agree that it is there. It certainly is a challenge, and this challenge needs to be tackled by a multidisciplinary team. We all know, as already has been brought out, the mortality is very high. It is not only the mortality, those who are saved after the surgery. Look at the surgery. When the surgery is done, you have enucleated the eye. Look at the cosmetic, the psychological impact of this, those who will survive this deadly disease. And to make matters worse, this country, the drug is becoming prohibitively expensive. Normal people cannot afford it. It is not available. Even those who can afford it, it is not easily available. So it is a double whammy for this country at this point of time. And it's very sad to see that the cases are so many, and the treatment is immediately not available. People are waiting for 5 days to get amphotericin B, which is not available. So I only hope the government is doing its best, and the things probably the things will improve over a period of time in next couple of days or maybe couple of weeks, and we should be able to treat these patients who need this treatment very, very urgently, very, very aggressively, and at the very outset. I think that would be suffice, because the time is already up there. I will not go into the symptoms and how to treat. We all know amphotericin B is the clinical line of treatment, and posaconazole and ivasaconazole are the alternatives available. Thank you, sir.
Thank you, General Sharma, for
Sir,
highlighting.
Dr. A.K. Singh has joined.
Very good.
Welcome, sir. Thank you, sir.
Dr. A.K. Singh, sir.
Good evening, everyone.
Welcome. Good evening.
Good evening.
Good evening.
I'm learning.
Oh,
Sir,
yes.
sir, please, sir.
We all
please
learn
open
from
your-
you. Right. So
Sir,
now
please
I would
open
like
your
to
video.
invite, a lot has been mentioned about the eye relation to mucormycosis. And if I'm not wrong, perhaps eye symptomatology was the first symptomatology which alerted patients to visit because there was redness, there was blurring, there was vision loss. Because if there was some nasal block because of the rhino component, then it is taken as normal. But the eye symptomatology was the one which perhaps alerted patient to go to concerned expert, and thereafter came that it is Muker. I still remember the first case of Muker, which I was consulted from a friend from Eastern UP, was through eye surgery. So we have with us Dr. Mahipal Singh. Dr. Mahipal Singh is the person who has created a history in ophthalmics in India, and he is who everybody knows. Mahipal, that Center for Sight, is the center of excellence for eye care, and he is responsible for it. Mahipal, would like to come and share your views about the ophthalmic involvement in mucormycosis?
Yeah, thank you very much, sir, for the kind words. I think since there are two ophthalmologists, Dr. Shishir Narayan is also there, and
yes.
Divided into ophthalmic manifestations of Muker, and then I'll be taking it in more detail. So maybe we can switch, and Dr. Shishir can do the first presentation, and I'll follow up.
Yes. Shishir?
Hello, sir. Can
Hello,
I have
Shishir. Dr. Shishir Narayan is the senior ophthalmic surgeon with Shroff Hospital. He's a retina expert and been associated with double helical for a long time. Welcome to you, Shishir. Please proceed.
Thank you, sir, and thank you, Professor Mahipal, sir, for letting the junior colleagues speak, and then you will give us the finer nuances of mucormycosis. Sir, can I have the screen sharing option, because it is not coming? Host disabled participant screen sharing. Can I have the screen, sir?
Yeah, why not? You can share, sir.
नहीं आपने ब्लॉक करी हुई है.
नहीं. Let me check.
Once we finish with Dr. Shishir and Professor Mahipal, we are going to request, we have been joined by our community expert person, which is very important aspect to understand where we are and what is going to be. Dr. Sunila Garg, and of course, let's not forget the dental field, the oral field, for which we are waiting for Dr. Mahesh Verma to come.
Yeah. So my screen, can you see my screen, sir?
Yes.
Okay. So I'll just recapitulate some of the important things, keeping in mind the higher number of fungal cases that we are seeing, and so many wonderful talks have already occurred on you know, the anatomical factors, why we are having ROCM more often, and why has this wave come up. So let me just quickly recapitulate what we have learned and what has gone wrong. So, you know, last year we had this same webinar, and we discussed how we have to protect ourselves and how we have to protect our patients. We had a new normal for everything, including the smallest thing, whether we are going to touch the patient with an earbud, or is the patient going to touch himself, and even the lenses that we use for ophthalmology that are going to have a cling film. The reason is we come very close to the patient, and therefore after the first wave we are in direct contact. We are breathing in and out, so we have to take extra precautions from other colleagues, maybe more than the physicians or other departments. And you know, Professor Mahipal Sachdev is a co-author in this wonderful work where they have done a review of the ophthalmic manifestations of COVID. And you know, when COVID came and it was realized that the COVID could spread from the tear, there was a lot of hue and cry amongst the public, oh, it can come from the tear. And a large number of people came into the eye clinic in the first wave, whether they had COVID because they had a red eye. And then we had a large number of vascular accidents. Now, eye is one fantastic organ that allows you to look straight inside. And what we were seeing were central retinal artery occlusion, retinal ischemia, and disc edema. And we were wondering whether it is really a hypercoagulable disease. And then, what happened was that somewhere towards the end of last year and the beginning of this year, we started having an increase in the number of endogenous fungal endophthalmitis. And this is a paper where from both Center for Sight and Schroff Eye Center, and I happen to be one of the co-authors, we reported 7 cases of endophthalmitis. And this endophthalmitis was culture proven. And this patient, you see, has got bilateral endophthalmitis, one in the right eye, one in the left eye, of the same patient, requiring a vitrectomy in this eye as well as in the other eye. And it shows Candida albicans here. And then another patient. So we had 7 patients, and we had more, but the report was of 7 cases. But these were moderate cases. The infection was a hematogenous spread. There was a definite spike. We were able to salvage all these eyes. They were from Candida and Aspergillus. And none of these were so locally destructive as we are going to see now. So then there was this second wave. I would say it was actually a tsunami of COVID with an epidemic of mucormycosis. That can be the way you can put what happened from March this year. And we had a locally invasive destructive infection of the orbital adnexa. Incidentally, this story had started last year, and 6 cases were reported in Indian Journal by Dr. Santosh Honawar and Professor Mahipal group. But we never knew that it was the tip of the iceberg that was coming. Now we are going to talk of various factors, but one can be anatomical factors also. Right from the first day when we were medical students, we were told that, you know, the nasal mucosa has got cilia, and it is supposed to, you take air from the nose so that it clears away all the things that are there in the air so that a clean oxygen and air can enter into it. And is this filter responsible for harboring the mycobacteria, the fungal elements in the nasal mucosa? We don't know. And then the skull is unique. It has got so many passages, the superior orbital fissure. Here is the nasolacrimal duct. There are openings in the brain, and this is the, you know, all the various foramina over here, because now there is a report that you can have fungus in the, from the pharynx, go straight to the intratemporal fossa, and from this foramen rotundum, go straight to the midbrain, and you get bilateral third nerve palsy without involving the cavernous sinus. So the anatomy, microanatomy and gross anatomy has become important. And you see all these 3 are lying very close. So there is anosmia because of the nerve involvement, and can the fungal element hitchhike along these spaces, and this very good haven for fungal growth if there is a patient with uncontrolled diabetes who has burnt his mucosa with oversteaming and taken Budecort inhalation. So all these things could be a cocktail for having rhinomycosis over there. So, you know, nowadays we are getting calls every day on teleconference. You know, my lid has come down. If I'm doing teleconferencing of 20 patients, at least 3 or 4 of them have got neurological symptoms. So awareness is very important, so much so that there is a complete dedication of the editorial this month to on rhino-orbital cerebral mucormycosis. So I will now request my senior colleague and an authority in this area and ophthalmology, Professor Mahipal sir, to please give us the clinical presentation and radiological findings and other things that are with the associated with this.
Thank you very
Professor
much.
Mahipal.
Thank you, Shishir. I'll just continue from where he left. As everybody has said, that there is I would also say, apart from the COVID tsunami, I think there is a tsunami also of mucormycosis, which we all are calling as ROCM, or rhino-orbital cerebral mucormycosis, and close to about 10,000 cases have been reported in India, and there would obviously be more cases which have still not been reported or put into the epidemiological study that is happening. It has become a notifiable disease today in almost 12, 13 states, and I think till everyone makes it notifiable, we may not get the number of cases that are actually happening in India. Now, why does, which has been discussed earlier, why does Muker inhabit the viral land, as I will call it, because it is a viral infection that we were talking about, and suddenly we got fungus coming in and causing the problem. The first thing is that, as we all know, that the COVID per se is having an effect on the normal immunity of an individual, and there is a decrease in the lymphocytes which is there. So there is a relative decrease in the number of lymphocytes, and the body is reacting in a way in which the immunity is going down. The second biggest thing that has been talked about is the comorbidities, and I'll be discussing in the comorbidities. The one of the most important is the diabetes, and the diabetes remaining uncontrolled. The third thing that comes out is the pulmonary function, which is getting decompensated. The fourth thing in the cocktail that is causing the problems is the use of intensive immunosuppressive therapy. And we have been talking about steroids, but apart from the steroids, the other immunosuppressive agents that we are talking about, that is also having a problem. And the fifth is the hygiene that we are talking about, and that is with severe disease and requiring mechanical ventilation and prolonged oxygen supplementation, that could be having the non-hygienic conditions of the nasal prongs, or the inhalation, or the oxygen concentrator through which the oxygen is being sent, the bottles that you have from which it is being sent. Now, again, what is very, very important is that whenever you have a viral infection which is causing a severe depression in your immunity, the chances of secondary infection, whether bacterial or fungal, increase. And the secondary bacterial, as we all know, is in the early stage, which is there. But the secondary fungal, as Shishir said, that we have reported Aspergillus, we have reported Candida, but the only thing is they are not disfiguring. They do not have a high morbidity rate or a mortality rate, I would say. That is why it has not been brought to the notice. But in two centers, that is Center for Sight and Schroff Eye Center, if we have 7-8 cases of endogenous endophthalmitis in all patients who had COVID, you can understand that fungal infections are relatively increasing because of the disease profile per se, and because of also the immunosuppression which is there. Now, secondary fungal infections, as compared to the secondary bacterial infection, they come in the middle and the late stages, or even when a person has recovered from the COVID. But what is very, very important is that this invasive fungal infection has a very high mortality rate. It is a highly disfiguring if the person comes out of it, and the mortality rate is pretty high. Now, what is important is that mucorales are the commensals which were found in GIT, but are also found in the nasopharynx and the PNS, and it's almost everywhere. So what you have to say is that mucor is in every breath that you take. It is very, very common. Even what was talked earlier is that the number of mucor cases in India, even in normal circumstances, is 10x. As compared to the developed countries or US and UK, etc. So we already had a high incidence of mucor, and the mucor is there in the environment to a large incidence. Now, in the COVID era, what is very, very important is, as I told you earlier, I'll just sum it up. Diabetes uncontrolled has been found to be present in various studies within India, to be present in more than 80% of the patients who have developed the mucor. Second is the uncontrolled and prolonged use of steroids. Prolonged use is something very, very important, and the overdose of steroids and it being given right from the day one. There are specific indications when you need to give steroids, but people are giving it left, right, and center. I will say it is an injudicious long-term use of steroids, which wasn't there when the first wave was there. And the home giving of steroids, you can take it at home, but the amount of steroids at the day when it is started, as Dr. Padma had said, like it's a Ramban. So people are in the mode of giving steroids. The third is the use of immunosuppressants, other like you have tocilizumab, and then you have elderly patient. The severity of the COVID, even the people are talking about the COVID double mutant being more severe, and that is causing possibly one of the myriad reasons for the entire thing to actually make up, I would say, a pot boiler for the number of number of Muker cases to be increased. Increase in the oxygen, possibly non-hygienic. We do not have studies, but we need to actually look at this particular thing, whether it is there. And the concurrent or intermediate early that you have in the young home cared and minimal or no steroids. So what is also compounding is that there are 10 to 15 to 20% of the patients who did not have severe COVID, who do not have diabetes, and were possibly not on oxygen, have also developed Muker. So there is something more that is happening that one does not know as to what it is. Now, when you look at uncontrolled diabetes and severe COVID, what is very, very important, and this has been told earlier also, and this is the study out of US where mucormycosis has been described in patients of coronavirus, and what has been seen even in the US, it's not that it has happened in India only, but what has been seen is 94% of the ones were poorly controlled diabetic mellitus, and you have they had diabetes, and 67% were poorly controlled, and severe critical COVID was present in 95%. So these are the compounding factors that a lot of the patients have diabetes, and 2/3 of them had very, very poor glycemic control, and 95% of them had severe COVID that was there. So what is very, very important is that when a patient of COVID comes, you have to do a triaging of them, you have to do a risk stratification, expedite the care, standardize the management, build protocols, improve outcomes, and also build a science into the management of this particular disease that is there. Now, basis of staging would depend on the sequence of anatomical progression as to whether it is rhino, whether it is orbital, whether it is cerebral. That is very, very important. And the severity in each anatomical location is something very important. It is not just that it is a total complex, but each has to be graded as per the severity, and that would change the management approach, possibly affecting the overall prognosis. Now, the pathogens which are there, which was talked about earlier by Dr. Padma, even Dr. Sharma, and that was the organisms can enter the blood via the following route. So it can be ingestion, it can be inhalation, and it can be traumatic inoculation. And it affects the body how? It affects the body by angioinvasion. There is definitely invasion of the blood vessels, which causes necrosis, which causes thrombosis, which causes onto necrosis. And this tissue necrosis will not allow the use of the antifungal drugs to reach adequate penetration into that. So therefore, you have to debride this necrotic tissue. And within ophthalmology, we may have to do exentrations for these patients, which is often very, very disfiguring and is having a problem. Now, these are the stages for the involvement. Now, what we are talking about is the nasal mucosa, limited to middle terminate, inferior terminate, or involvement of nasal septum, and bilateral nasal involvement. So this is the staging that you have when it is involved only in the nose. And what are the symptoms? The symptoms are what a person has is the nasal stuffiness, nasal discharge, foul smell, and epistaxis. Now, when you go on, this is going to be the signs which are the foul smelling, sticky mucoid or black tinged or granular or hemorrhagic nasal discharge, as you can see here, erythema, and you have the discoloration. So if a person does an endoscopic examination, an ENT person does an endoscopic examination, this is what you are likely to see in the person. And then you go on to the diagnosis. You have to do a nasal endoscopy. You can do a contrast enhanced MRI or a CT, and you can pick up the lesion. Deep nasal swab for endoscopy will give you on histopathology and on KOH screen that is there. Now let us come to the second stage. So first stage is only nose. Second stage is involvement of paranasal sinuses. And this can again be divided into various stages. 2 is one sinus, 2 ipsilateral sinus, 2 sinus, bilateral parasinus involvement. So these are the details. The symptoms in stage 1 will be the same, that is the nasal symptoms, plus you will start to have the facial symptoms which are there. So facial pain will be there, facial edema will be there, and goes on to the maxilla, zygoma. You have dental pain, systemic symptoms, and fever, malaise, etc. Now, these are again the same. Localized sinus tenderness becomes very, very important along with the edema that you have. Again, diagnosis, endoscopy, and you can do direct microscopy, culture, and do the other things. Now the third stage, so first stage is that you have the nose, then you go on to the paranasal sinuses, and then you go on to the orbit. So that is the third stage, which again has been divided into 3A to 3D, and it can start with the NLD, go to the medial orbit, and go on to the bilateral orbital involvement. So in this particular case, what you will see is conjunctival chemosis. Motility of the eye gets restricted because it is all over around the eye. You can have, as was talked about in the foramina, you have ptosis, you have proptosis, infraorbital nerve anesthesia, and then you go on to central retinal artery occlusion, etc. So I'll just show you as to how exactly the various pictures can go about, and then you do again the diagnostic nasal. By far, diagnostic nasal endoscopy, taking a swab, taking a culture, and doing biopsy is the hallstay of the diagnosis. And then you can go ahead and you can have the MRI and the CT. So this is a periocular edema, progressive change in the color of the edema. And then you have the isolated medial rectus muscle, which is thickening, MRI orbital signs which are there. Then you have restricted motility of one muscle, but with multifocal orbital involvement, which is there. Then the periocular edema tends to start, extraocular muscle restrictions, medial and superior orbital invasion happens. And there is a rapid progression of ptosis going on to proptosis and chemosis, as you can see in these particular cases. Sudden onset, then you have the ophthalmoplegia, orbital apex syndrome, etc. And you can see that the person starts to see doubling, and the person is not able to, has a blurry vision, and the person is not able to move the eye. Sudden loss of vision because of inflammation of the optic nerve, but more often than not, it is the central retinal artery occlusion which can happen. It's a compressive optic neuropathy, and you can see here superior orbital fissure, all the nerves and the blood vessels, and this is where you get the involvement, and the vision just goes down. So these are again the pictures. You have to drain it, and if the FES is not working, that is when you have to look at exenteration. So first is that, and then obviously you have to start with the preferable, the liposomal and amphotericin B. Even if you don't have the liposomal amphotericin B, you can go on with the normal amphotericin. And this is a bilateral orbital involvement. And then finally, stage 4. This is when the CNS gets involved. And once the CNS gets involved, the problem is that the mortality rates goes and increases significantly. Diagnosis goes into the domain, as I told you, of the microbiologist, deep nasal swab, endoscopic guided swab, microbiopsy, the debridement that you do, and these are the cultures, etc., that is done by them. CAT scan can help in the diagnosis if you are not retrieving the microorganisms. Contrast MRI will also help you in these cases. In the management, when the patient, you have rhino-orbital cerebral syndrome, whether the patient is at that time RT-PCR positive or negative, you will accordingly make, and you will either admit in the COVID-19 with COVID-19 or in the critical care. Timing is the key for the treatment. Mortality, even with treatment, is 30 to 50%, and delay of 6 days in starting the treatment increases the mortality to double, which is from 35% going on to 66%. Delay is much more punishing in the rhino-orbital syndrome with COVID-19. So this is just, I think I will skip over this, but supportive clinical treatment is something which is very, very important. If the patient is improving on the presumptive diagnosis of ROC, CM, then you keep on waiting and just observe the patient. But if it is increasing or clinically worsening, what you need to do is 5 to 10 milligrams per body weight of with strict metabolic control that you do amphotericin B. And if amphotericin B renal toxicity is there, you cannot give it. Otherwise, from amphotericin B, you can use, because there is shortage, you can use isavuconazole IV, or you can use posaconazole. These are the other antifungals that can do. Normally, posaconazole, etc., are supposed to be fungistatic. Amphotericin B is supposed to be, though it's a 50-year-old medicine, it is supposed to be fungicidal, but we haven't really progressed in getting a lot more medicines which is there. So similarly, depending upon the involvement, these are just the ways in which you are going to do debridement. Necrotic tissue has to be removed. The ENT people come in first, and they can go with the burring, and they can actually remove the entire orbital part, or we are called in to do the orbitotomies, or the orbital exaggeration, etc. And that is a part and parcel of a severe worsening disease that you have to sacrifice the tissue that is there. This is orbital exaggeration. As you can see, this is a good outcome. This is not a case of COVID or Muker for COVID, but otherwise, and you can see after exaggeration, even a cosmetic rehabilitation is good. You don't need to do an orbital exaggeration in this particular case. And in this particular case, even the medical treatment helped. So finally, what I just want to say is that can we prevent it all? So prevention is the judicious and supervised use of corticosteroids in compliance with the current preferred practice guidelines. That is very, very important. Next is, even the immunosuppressants should be used only if there is strong indication of a cytokine storm that is happening. Diabetes mellitus, whether at home or in the hospital setup, needs to be aggressively monitored and controlled. Regarding the aseptic precautions while administering the oxygen, sterile water for the humidifier, daily change of sterile humidifier and the tubes is something very, very important. Personal and environmental hygiene. Betadine mouth gargles, not to be used in the nose, but betadine mouth gargle, barrier mask covering for the nose and mouth, and that too with a clean mask. Some people are nowadays trying to blame that if masks are overused, that can also lead to the fungus coming in. And consider, again, this could be more aggressive, but consider prophylactic oral posaconazole in high-risk patients with greater than 3 weeks of mechanical ventilation, 3 weeks of supplemental oxygen, and more than 3 weeks of systemic steroids with uncontrolled diabetes, with or without ketoacidosis. So ketoacidosis, ferritin levels, and nowadays zinc studies are also coming in. These are possibly the things which can increase the incidence of mucormycosis. And corticosteroids to give or not, again, you have to work with the WHO, which strongly recommends only for severe and critical cases. And these are the various steroids that you have. These are the AIMS guidelines which are there, which have removed corticosteroids, which are not there in the mild disease. No steroids here. It is only if you have the moderate or the severe disease that you will give steroids, which is there. And these are the various steroids that can be given in the various doses. But the tapering has to be much faster once the symptoms goes. There shouldn't be a long-term steroid use that is being said. So finally, what I will say is that even though we are having a lot many cases, the incidence is close to 1 in 1,000 in admitted patients and 2 per 10,000 in all the PCR positive cases that have been seen so far in India. General screening may not be possible, but the warning has to be given to the patient for high index of suspicion of any ENT problem coming afterwards or an ophthalmic problem, and one should be explained about the early warning signs, and then it is mandatory for an ENT examination that needs to be done. So finally, to sum up, moderation in steroid use, I think, is something that is controllable within the physician's ambit. Needs to be educated, the physician, and the patient should not be able to get these steroids off the counter. Moderation in immunosuppressant use like toxicizumab, awareness of the red flags, and an ophthalmic and an ENT consultation. And whenever there is a high index of suspicion, it has to be a multidisciplinary approach with multiple departments coming in, but timely surgical and medical management is something important that is going to save the patient from mortality and also disfigurement of and a high morbidity that is there. So this is all that I wish to say as regards the Muker. It is something which is real, but I think as Shishir was saying, there is enough and more panic among the citizens of India, and any conjunctivitis, anything red eye, people are calling ke ye muker to nahi ho gaya, fungus to nahi ho gaya. We have to tell the patients that if you are not immunocompromised, if you are not having uncontrolled diabetes, and even that it cannot transmit from a patient who is having to a normal healthy individual, we have to tell them that there is a particular triad or a quadrant over 4 or 5 things that are mixing together for a person to get COVID and for a person to get Muker in a patient of COVID. That needs to be told. Panic needs to be suppressed. there are a lot of panics and a lot of WhatsApp medicines that are going on and things like that. So,
Thank you. Thank you, Maipal.
thank
I
you.
think thanks to Shishir, both of you has given absolute clear picture of the ophthalmic involvement, and not only ophthalmic. Thank you, Maipal, for covering for a little bit ENT also, sinus. As well as I think it is important for us to take all step 1, 2, 3, 4, 5, 6, 7, which have been enumerated by you. And very importantly, you said that at an appropriate time, early as possible, ENT concern, ophthalmic concern, and perhaps a dental concern. Perhaps a dental concern. So from that angle, can I go to now my colleague, Dr. Professor Mahesh Verma? I have already introduced Professor Mahesh Verma to you, our Vice Chancellor of IP University and the Professor of Dental in MAIDS. He had been President of DCI and everywhere.
Thank you, sir.
Mahesh, will
Yeah,
you like
thank
to
you.
will
Thank
you like
you.
to share the
No. I will just take a couple of minutes. I am not going to share any presentation, but I'm just going to talk about some the dental part of
yes,
Muker.
dental.
And thankfully, in all these presentation, it was only Dr. Mahipal that who did use a word of a dental pain, and my eyes, my ears really. And
That's
with all these possible causes, thought of causes, nobody ever thought that our mouth has so many routes for the bugs and the fungus to get in. Is also is also very important, because it can start there. I'm not saying that everything doesn't rest there, but there is something called rhinoalveolar or rhinomaxillary. And because I was taking census that how many cases are happening now and how many cases have come in the past. So many times these patients in early stages, they come to a dental practitioner because they have some dental pain. They may have some oral cavity related problem, because it can it normally starts in this area. And also it is not only the maxilla, sometimes it's also known that mandibular can also be affected, more maxilla, because maxilla is more porous, it's more vascular, and it's much easier for the fungus to multiply, and filament is there. So that is it. And that what are the red flags for anybody who's coming to a dentist, or initially initial days, there are not much of a problem. The patient complains of a very non-specific pain, and this is a very enigmatic, because this non-specific pain is non-odontogenic, because we look for a pain, we look for a dental cause, but this pain is usually nothing to do with dental. Everything else looks healthy. Patient has got a little bit of halitosis. Patient may have a difficulty in chewing, or may have a difficulty in opening the mouth. So there is no reason for a dental pain initially. But what happens that in couple of days, as the disease progresses, couple of days, there could be ulceration, there could be multiple sinuses, and these sinuses are very peculiar, that these sinuses are not through the bone. These sinuses at the tips of the gum, gingiva, because that's where the sinuses can come up very quickly, unlike the sinuses we see in actinomycosis or in osteomyelitis. Those sinuses are bony sinuses. And also the teeth may become mobile, and there could be a white patch, there could be ulceration on the palate. And one very pathognomic feature is paresthesia. Patient says that I'm getting a little number, not able to feel that, getting that tingling sensation. And what is very strange, that it all starts in a canine fossa, in a premolar area, because that's the area where it starts. And sometimes in a few advanced cases, the premolars can just fell off on its own because they become mobile and they fell off. And also in some cases where a dentist has done extraction, the wounds don't heal. There's no healing of those wounds. So all those things can happen. And the typical is that the draining sinuses are not from the bone, but it is on the gums. And there are multiple. If you look, they're more like a boggy gums and a swollen, and at the tips there are sinuses. So it could be a case of a sino-alveolar or a rhino-alveolar or rhino-maxillary, and which ultimately go into ROBM and then cerebral this thing. So what do? Normally, dentists take X-rays to find out. And commonest X-ray these days we take is CBCT, which is a cone beam CT. It's a dental CT, like ENT people take CT-PNS. So we do CBCT, and most of the dental offices these days, we have a CBCT. It can give you good pictures of the sinuses, all these areas, but also a lot of dentists take OPG, but OPG cannot give you a good picture about the back portion of the maxilla. And sometimes in a premolar area where there is a sudden mobility of the teeth, we take a smaller dental X-rays, what we call intraoral periapical X-rays. And as I said, that it is most commonly happens in maxilla, but it can also happen in mandible. But when it happens in mandible, we have to have a differential diagnosis with osteomyelitis, whether it is, because it's less likely to happen in mandible. When you see an X-ray has a very peculiar pictures. They have a hypodense black spots. And as I told you that, the outer cortical layer, usually in a canine fossa or a premolar area, that is the area affected, and there's a thinning of the bone and all those things. So you can make out. And whereas of course, in advanced cases, there'll be a visible sign, there'll be ulceration. So obviously there'll be hard palate and alveolus that will be affected. Coming to the management, I know that if you look at the guidelines, maxillofacial surgeon is a very important part of the team. And they can either, in the initial stages on their own, they can underdo surgery. Because we do maxillectomy, mandibulectomy, a lot of oral and maxillofacial surgery, or as a part of the team, with the other team like ENT and eye, and of course, sometimes neurosurgeons or a plastic surgeon, they got to debride, they got to do a surgical management, and that's the surgical approach. But the biggest challenge, as Dr. Mahipal also said, that some of these cases, if they don't become fulminating, if these cases do not, the patient survive and patient stabilizes, rehabilitation, that's a big issue after them. Because I'm sure I would like to use this platform to tell my friends that we in a dentistry, we have a specialty called prosthodontics, and that's incidentally my specialty, which deals with maxillofacial prosthesis. We make maxillas, we make mandible, we make artificial noses, we make artificial eye, ear, and also we these days use implants to rehabilitate these patients, and we use even zygoma implants to provide the dentition. So what is the carry-home message? The carry-home message is that whenever a patient with such a vague complaints come to a dentist, we should look for a history and also look for any other symptoms of a nasal congestion and other areas, also eye issues, because it can start there and in a couple of days can really spread. It is said that it spreads faster than even malignancy. So that's one. And the second thing is that if there is any red flag, the referral should be quick. We should not waste any time. And also, we should not carry out extractions, which has been Muker cases and have been stabilized. I think all the dental treatment in such cases to be deferred for at least 3 months till they become stabilized, and then we can do our dental surgical part or dental extractions. And another thing is that all these COVID centers where there are COVID, There should be a vigilant oral and an ENT examination regularly. And I think the most important part is the oral and the nasal hygiene. And everybody said that it might start there. It could be mouth, it could be nose. And nose, of course, somebody said about steam inhalation causing ulceration, but mouth has got billions of commensals, fungus infection all the time, and we have all the invagination and all the pockets around the gums where all these commensals can very easily get into the body. Thank you very much, sir.
Thank you, Mahesh. Thank you for highlighting. Of course, we cannot ignore any of the dental symptoms in normal scenario also, but especially nowadays, if there is any such dental symptoms which has been mentioned by Professor Mahesh Verma, perhaps a special attention has to be paid that cannot be ignored. Thank you, Mahesh. So after listening to all my clinicians, there is a binding force, and the binding force, which I always call a expert, which is perhaps the master, which like pituitary gland is the master orchestra, the same way the subject, the expert of public health, who binds each and every specialist together on a common platform, who is perhaps very responsible for creating policies for prevention, alarming the policymakers, the society, the public. And that is what I would like to invite my colleague, Dr. Sunila Garg, who is a Senior Director Professor of Excellence in Department of Community Medicine, Maulana Azad. And if I start enumerating where she is as advisor, including WHO, ICMR, I think it will take more than 1 hour. Sunila, will you like to come and share your views?
Yeah, thank you, sir. Thank you. It was treat listening to Dr. Sharma, Dr. Mahipal. First of all, to you, sir, that is there, and Dr. Sharma, and all of whom I can, Dr. Verma last day listened to. But my question, to all the panelists is that on 10th May 2021, we had 1,12,85,349 cases. And on 24th May, we have got 2,69,47,621 cases. That means
I think you are referring to 10th April, not 10th May.
No, I'm referring to 10th March and I'm referring to 24th May. I'm referring to...
Okay, 10th March. Okay.
So that means there has been increase in 139% cases which are suffering from COVID infection. So now I just want to, kind of ask the, panelists to look deep down into that primarily now it is because these cases have been there since time immemorial. And, they have been, over a period of time, we have got 139% increase, which is an increase which takes us across, from Maharashtra, where there has been 149% increase, in Kerala, 118% increase, and then in Uttar Pradesh, we have got 177% increase and all of that kind of. So, and we have got 718 districts. So, when I was preparing guidelines for the ministry just a week back for the rural areas, the question came to my mind was that primarily we all talked about steroids. We all talked about, uncontrolled diabetics. We all talked about, that India is a diabetic capital of the world. We all talked about, the Delhi is diabetic capital of the country. That is important part. But you see, non-communicable diseases are there in US. Non-communicable diseases are there in all the developed part of the world also. But what is that, or in Southeast Asian region, from the epidemiological perspective, I think that why it is so that it is only in India we are bound to see cases. Is it only mask? Is it only hygiene? Or it is only industrial oxygen? Because Dr. Mahipal was also there with me when we talked about, yesterday we were there on a platform. So I think somewhere we need to look deep, down into that. And under Ayushman Bharat, what I want to bring to my friends is that we have got 1.5 lakh health and wellness centers. When we talk, the cases are going to go over there. Now in rural areas, we see a huge surge of cases, and number of cases are going to go there, which are going to be managed by, community health officer who is BSc in nursing with the bridge course. They are going to be managed by even Ayurvedic people also. So then, they go to, and also we have had a provision of, community care center, which is going to be managed by Panchayat. And, the volunteers are going to be there from the community itself. And then they go to the district COVID healthcare center. And further, then they go to the dedicated hospital, that is district hospital. Now, when we talk about, so much of population of 138 crores nearly of our country, and, so many cases which we are talking about now. So primarily to my experts, my epidemiological perspective is that we need to have guidelines for all the levels. That means I talk about district level, or some persons, some of my panelists said that, our panelists said that we need to look at the district hospital. Now we have to go by the fact that, because everybody will not necessarily come, primarily because most of the cases we have seen when they are convalescing. So what is that makes them important? What is important that predisposes them during convalescent period? Either their home hygiene is not this thing, because you see, even when you clean your refrigerators at home, the black part in your, the plastic region is nothing but mucor. It is everywhere, kind of. So that is where I feel that we need to have standardized guidelines, which should be there for the district level, which should be there for a PHC medical officer, and also for the community health officer. Because ultimately from there, the message is going to go down below. And what kind of, we have to be much more conservative, because I see that with kind of extensive surgeries and all, I see another burden of mental, depressions or mental, I'll say, health issues, which is going to be, because it is, it is, uh, very difficult to listen to, the extensive surgeries, how long, is going to be the survival period after that. So these are some of my important questions from the perspective of Ayushman Bharat, from the perspective of a public health expert. I think we need to look into it, and there are some do's and don'ts. If this panel comes out with some simple do's and don'ts, which can be every day flashed out on the TV channel, that means, if you're talking about that, must watch the blood sugar regularly, must see that, the person has got any symptom of mucor, that simple things, kind of. And I think we need to kind of, go from this platform to Ministry of Health, so that, these guidelines are there, which are talking about, from the public health perspective, so that they are incorporated on the Ministry of Health and Family Welfare's website, along with the ICMR's website, so that, they are implemented in true spirit at the district level and down below. Tertiary levels have got their own role, but we are catering to a segment of population at the district level. So at a tertiary level, so we need to look from the perspective of whole of India. So that is one of my objectives, because now it has been declared as a notifiable disease under, Epidemic Disease Management Act, but we need to see that exactly the disease is notifiable. The doctor is going to notify. It becomes mandatory on part of doctor and obligatory on part of doctor. Everything, responsibility has been passed away to doctor to notify the case. But then, is prescription auditing going to be done, or is, the stay audit is going to be done of the patient who is there in the hospital? So these are some of the things which are in my mind. I think as a public health expert, which is there for all the experts to, kind of think of. And then I think we need to come out with a very, very, logical solutions, which have to be taken at a nationwide level. And this will also, kind of, give us as to exactly, what kind of, studies we can plan out from epidemiological perspective, because I gave you the figures of 1 crore 12 lakhs and 2 crore 69 lakh. What happened, basically, during this period? Why the convalescence was there at that time also? Is it because of the variant strain of virus that made us much more vulnerable when we talk of B.1.617 strain of virus, or it is, but then that is there in Britain also. So that's where we need to look at it, from that perspective. So these are my views regarding mucormycosis. Thank you, sir.
Thank you, Sunila. Thank you very much. Dr. Mahipal, you did mention when you are talking about management that the entire experience should add to the science. And that is what Sunila said, that whatever we are experiencing is undesirable. We shouldn't have faced it. But the point is, once we have faced it, it is very important for us to analyze why it happened, and what sort of preventive aspect. And of course, the way it has happened all over the globe, I mean, in India, the entire globe is watching us. And perhaps it is not giving a very appropriate message to them, because there is something lacking with our care. So with this, I think we have finished the opinion comments of all our experts. And before of course, at the end, I will request Dr. Mahesh Verma to give a brief summary. But before that, of course, I would like to have my expert of double helical magazine, Dr. Gyani Ji, who is the Director General of ASPI. Dr. Gyani, you are there?
Yeah, thank you very much.
Just a short expert comment from your side, because you are leading the entire hospital group for the country.
Yeah. मैं एक बात कहूँगा, to be very frank, first time I can say this kind of experts you have brought at one place. I think this is very admirable. I think the contents are so academic, so genuine, so real, that I must appreciate contribution by all, Dr. Mishra, Dr. Sharma, Dr. Mahipal, Dr. Shishir, and of course Dr. Mahesh Verma and our own Sunila Gar. इस तरह का सेमिनार मैं कहूँगा बहुत कम मैंने देखे हैं. मेरा सिर्फ एक ही पॉइंट है कि जब कोविड वेव फर्स्ट आया था, this was new to us, we were not prepared, but still we managed. But when wave 2 has come, we had experience, but we were found to be wanting. The reasons है, of course, mutation है या और सब कुछ है. But my question, which I wanted to ask, which Sunila actually has in a way replied, that this mucormycosis has come only in India. Is it so? Because wave 2 is coming to Europe also, it has gone to USA also. But what is this, that mucormycosis we are seeing only in India? So I think Dr. Mahipal showed a lot of factors, whether it was oxygen or it was diabetes or other all factors, very nicely he showed. So if somebody can really bring this aspect, that if it is happening only in India, only post-COVID, then I think it should not be difficult to get the pinpoint the answer. This is from my side. Thank you very much.
So, Dr. Gyani, I think it's a very important point. Why in India? This is very important. Though it has happened in other places also. Dr. Mahipal did mention certain publication of the United States, but not to this extent. Why in India? And this is what we have to understand, and perhaps we have to analyze with the joint platform like this, with the help of public health, and that will add to not many things when we deal. God willing, we don't deal it in future. Sunila, there is a question. Sunila,
Yes, sir.
Do you think there was some sort of instances during Second World War of mucormycosis, or I'm wrong?
Sir, that I also tried to see, but I could not locate that. But
there was some sort of reference.
The earlier reference was there in 1885, which was again,
1885 reference,
and then 1993, that was taken and again, published, but later on. That is the historical evidence what we saw. But beyond this, but then those studies will also be observatory studies like Spanish flu. We can say that, okay, we did this. But, we have to look at the kind of science behind the whole thing, which, bothers me that somewhere, we all throughout, we know that we can't say that 100% of our patients are diabetic uncontrolled, because developed world has got far more, of course, we are now, 69 million cases who are, nearing 69 million by 2025 who are going to suffer from diabetes. But, indiscriminate, we do have polypathy also. We do have, alternative system of medicine, because out of these 2.69 lakh cases, quite a number of them, because these are not the cases who have come to the hospital. These are the cases which we have, got by contact tracing, or through by rapid response team. So, we need to look at those cases who have developed versus those cases who did not develop. What was so different about them? Were they not all of them, out of them, none of them were diabetics, none of them were prescribed steroids?
I think
So
you are
somewhere we
correct,
need to
Sunila,
look
that
at
it requires total detailed analysis. And today we are perhaps, yes, Dr. Mishra.
I just wanted to ask Dr. Sunila Agar, as ICMR constituted a task force, and have you made an instrument to be filled by each and every hospital in the country who is treating mucormycosis to get all, at least some of the answers to, I really learned a lot from Dr. Mahipal's presentation on eye, and also somewhat Dr. Mahesh Verma also enlightened on dental, and obviously we have no details of cerebral form. Most common procedure is endoscopic sinus surgery, where patients are recovering, and also exentration is the most common surgical procedure. But I think what I wanted, at least ICMR to urgently institute a task force, an instrument, send it to all the hospitals to be given this notify, because once it has been termed as an epidemic, it is a notifiable disease now. So instrument, get this data, what we are discussing here, get to the bottom of this issue. At least we have such 9,000 patients. It's not a small number, howsoever we may say, commensurate with our population. It's a huge number. We had only few cases, and I saw that article also published by the ophthalmologist. I think Dr. Mahipal is the co-author, 6 patients in the first wave. And it is just recently published, where they have given some details of these patients who got this. But we have not had too many good publications from India. Unfortunately, I'm sorry to say that. We must have those, and we are talking quite a lot, but we are not publishing enough on even mucormycosis in COVID-19. I think that is something which has to be taken with a lot of urgency. Not because these patients, many of them will not survive, and many of them will survive. So at least we can get to the bottom, whether it's oxygen, whether it's humidifier, whether it's tubings, whether it is steroid, whether it is something else, whatever. And remdesivir, Dr. Mahipal, I would just like to flag, even remdesivir has been used extensively without indication in many patients in early disease, late disease. Doctors have prescribed it, our allopathic doctors have prescribed it. And we all know that any antiviral medication is a immunosuppressant also, not only tocilizumab. Fortunately, tocilizumab was not available in this during the second wave, but remdesivir was available, and this was the spurious remdesivir and all those kind of things. And despite, I will not name anyone, despite my telling to people, very senior people, physicians, that why are you prescribing remdesivir? Why are you let the relatives run around for plasma when it has no benefit to give? But it is being done even today. So that is something. And steroid, of course, I had to stop steroids in many young lads who were put on 32 milligrams just on phone by a hospital. So I think all this has happened here. I said, it is very difficult to stop a medicine which some other physician has started. But I said, no, you don't need it. Please. Period.
Sir, absolutely
Mishra,
very right.
you are absolutely correct. Sunila, I'll
Sir,
come to
my
you.
worry is that when you see,
Sunila,
we don't have less prevalence of NCDs in rural areas. We have got equally high prevalence of this disease in rural diabetes as well. And their indiscriminate use of steroids is very high. So somewhere I feel that even if ICMR task force is there, that has got to focus on. Now, since we have got the guidelines for rural areas, somewhere it should form an integral part of those guidelines as well. So if we write to Dr. Balram Bhargav and Samiran Kanda, that will be, I think, good.
I think we all can write to DGICMR.
Yes, yes.
It should become the very structured form of registry, mentioning all the parameters, so whatever is important, so that
Yes.
it becomes a piece of literature for us. I think I would like to invite Dr. Vijay Agarwal, who is our advisor of double helical. Vijay, are you there? He's president of CAHO. Vijay?
Yes, sir.
Yes.
Yeah, Doc.
Can you give
Sir,
your
I have only
short-
a number one. I would like to say that this has been a very informative session. Extremely thankful to each one of the speaker for brilliant talks. But I'll go along with Dr. Sunila and just want to say one thing, that in our country, even when we make a disease notifiable, what is the purpose of that notifiable disease? If we cannot try to collate all meaningful information from each and every patient which has been notified. So this is a very, I think, not only for this disease, I think for all notifiable diseases, even if there is a need of an act or whatever has to be changed, that the data of those particular patients need to be even made public anonymously. I don't want to know whether Mr. Verma got it or Sharma got it, but at least all other data points should be collated, should be made public. Therefore, only the epidemiologists and the public data analysts will be able to give answers to whatever we are groping for. So at the moment, we can keep on repeating whatever we already know. Unfortunately, we don't have the answers that why has it become like an epidemic in the last 2 months. That's a big question which needs to be answered by this galaxy of people. But I think, please do, let us write to the Niti Aayog or whosoever is the authority body, that let's get the data and let's get, like what Dr. Mishra talked about, we have to make an extensive kind of a questionnaire, a survey form, which has to be filled by each and every person who is notifying the disease and then analyzing it. That's my just humble submission. Thank you.
Vijay, you correctly said that we have to perhaps bring a detailed form, and the registry has to be so extensive, and each and everybody who is perhaps notifying it should be trained before. So I think we had a wonderful discussion with the help of all my experts in front of me. And Tiwari-ji, quick question.
Just to create a Google form, a pro forma, and send it to every hospital, make it mandatory that they must respond to that. I think there's no exception. It should not be. Then only we'll get some data, and it can be done digitally. That's not something that people will just create a Google form to be filled by for each and every patient diagnosed with mucormycosis under treatment. I think it can be done. It's not difficult.
HMR will be the right place to circulate it. Perhaps
So it has to be circulated to all the tertiary. We know the hospitals by now, and maybe we can take it according to the place from where these patients have been there. So it can be also done like that.
So Dr. Mishra, our form will be ready over the next 10 days. That is already Ophthalmological Society and Association of Ophthalmoplastic Surgeons in India, and we are going to circulate it to all ophthalmologists.
Wonderful.
Wonderful. Wonderful.
So the form must include certain things like, for example, whether the oxygen used was industrial or not industrial, whether what kind of water was used, so many factors which have been incriminated by many clinicians, right? Whether the steroids were started on day one, how many days steroids were given, whether glycemic control was there, not there. So it has to be a very extensive, you must take help of the epidemiologists who are able to, people like Dr. Sunila will have access to those experts to create that kind of a form, and it should be done, in fact, for all notifiable diseases.
Yeah, so
and I think that let's make a beginning with this COVID.
Absolutely, I think so. And
I think this
probably,
platform,
Dr. it will be better if we take inputs from the physicians, and we take input so that it becomes a kind of a holistic, because once this form is being rolled out, let us get the overall picture of it, because you see, it may affect eye, it may affect, because if 10 times if we are asking for information from each society,
No, it has to be a very extensive form once for all. That's
yeah, I feel that
So
way.
Leela, you must take lead into it.
Yeah.
Yeah,
Right?
but Dr. Mahipal is already taking. I will
Of course, no,
compliment.
no. From public health point of view, of course,
Yeah,
each and every clinical group will be with you.
Yeah, definitely.
तिवारी जी, कोई क्वेश्चन है, क्योंकि हम टाइम खत्म कर चुके हैं. अमरीश तिवारी जी.
Muted हैं आप तिवारी जी.
Sir, there are two questions. One question for Dr. Mahipal and another question for Dr. L.R. Sharma.
जी बताएं.
Sir, first question is what this question raised from Sanjeev Varsade from Department of Science and Technology.
Yes.
Question is that what precautions diabetic patients treated with the steroid for the COVID can take to avoid this fungi development?
Yeah.
For me or for Dr. Sharma?
Dr. Sharma.
Sir. Hello.
Should I repeat?
नहीं सुन लिया उन्होंने.
Sir. I have heard the question. That's something very, very important, of course. See what personally, first I tell what I have been doing. The day I see these patients, and if I find that we look at their weight, their height, and if they have comorbid conditions, and if diabetes is there, I do their HbA1c the day one. When I prescribe my medicine, I tell them to do including the basic inflammatory markers plus HbA1c. And I tell them to keep monitoring their blood sugar every day. And if need be, I have even given them at home. You can start them on a long-acting insulin in addition to, because most of these patients are at home. So what I do, and I think people can do it, but this again is a question of different clinicians will have their own viewpoint. But what I have done is that to some patients where the sugar control was going haywire, I have added long-acting insulin along with oral medications. As say you start either Degludec, or you have Lentus, or you have any of these Glargine hai, aapke paas Tesiva hai, you can give them a long-acting insulin so that you at least get a basic cover for 24 hours and he can continue with medication. And then you judge his blood sugar and tell him, when you are reviewing every 3 days, you tell him accordingly, can then change the drugs or you can increase the dose of insulin. That is one. And number two, he has to be told that his diet control has to be very, very strict. And I think that is all we can do. And steroids, of course, should not be started. I will repeat it again. Steroids should only be started when there is a fall in saturation or fever is not settling down by 6th to 7th day. I think that may be an appropriate time to start steroids. If somebody day one is going into saturation fall, believe you me, his onset of symptoms will be different, because what most of our people are trying to do is the day you get a positive test, you try to calculate from there. If you go into the history and try to look deeper into their symptomatology and look at who would have they contracted the disease, you will find that probably by the time the lung is involved and he is getting severe cough, it is already 6 to 7 days down the line. So therefore, the take-home message for diabetics with COVID is that please delay steroids as much as you can, because if your saturation is okay, you don't need steroids in the beginning. People with 14 score have been treated without steroids, they have not needed steroids. It is not a must that everybody will have a fall in saturation. It is only when you have a fall in saturation that you think of steroids. Fever, only if it is so distressing that it is not coming down and it is going down 7th and 8th day, and you find that there are inflammatory markers are very high. I think that would be more appropriate for a diabetic patient to have a.
Thank you, General Sharma. Thank you. I think what is the next question to Professor?
Sir, one question is from Parmila Roy from West Bengal, Calcutta. So she's asking about how one can know what is the mucormycosis in layman term. Is it a part of COVID or it is an influence of COVID? Is their symptoms correlated with the COVID symptoms? If there is a problem, then where to go? Either COVID test or mucormycosis. Let me understand.
Basically, what I told is that this is not something that happens in normal people who are not immunocompromised. This is happening in patients who have had COVID and who are immunocompromised, and have been on apart from immunocompromised, they have been also on steroids, or they are diabetic and they are going into they have blood sugars of 400, etc. So it's not a question. That's what I said, that there need not be a panic. A normal person will not get Muker. It is as rare as it was earlier. It is only if there are certain compounding factors where there is an interplay of various things that is happening. So the panic need not come that like we are getting a lot of calls. I even got a call today from a very senior individual कि उनकी wife को COVID तो नहीं हो गया. There's just a little swelling here on the lid. So the people have to be told that there has to be a COVID patient who has comorbidity. It's very, very rare for a normal individual to get Muker. So that's not going to happen.
Sir, one more question is apart from black fungus. This question from Dr. M.C. Mishra Shah. Sir, this is a question for Sanjukta Ghosh from Nanderi, Gujarat. So she is asking about, पहले तो ये बात होती थी रेमडेसिविर दिया जाए, फिर आपका बीच में प्लाज्मा थेरेपी पे काफी जोर दिया गया, लेकिन एकाएक इन चीजों को कोविड के ट्रीटमेंट से अलग कर दिया गया. यह एक मोनोपोली है या वाकई में गवर्नमेंट का कोई अलग स्कीम है? सो क्या इस पे आप कुछ प्रकाश डालना चाहेंगे?
इसमें प्रकाश इतना ही है संयोगिता जी कि ये ड्रग पिछले वर्ष आई थी और DCGI ने इसको इमरजेंसी अप्रूवल दिया था एज ए इन्वेस्टिगेशनल ड्रग. और भारत में अभी अनफॉर्चुनेटली मैं तो बहुत बार बोल चुका हूं कि DCGI भी जब इस प्रकार का कोई भी अप्रूवल देते हैं उनको साथ में ये भी कहना चाहिए कि ये उन्हीं सेंटर्स में इस्तेमाल होगी जहां पे ट्रायल कर सकते हैं. हमारे यहाँ क्या होता है कि हर फिजिशियन anybody and everybody start using that medication, and that is what happened with remdesivir also. In the meantime, जो WHO है उसने 30 देशों में 11,000 रोगियों पे इसका परीक्षण किया और उसमें से आधे लोगों को रेमडेसिविर और 4 दवाइयां उन्होंने देखी. इंटरफेरॉन देखा, रेमडेसिविर देखा, हाइड्रोक्सीक्लोरोक्विन और एक एंटीवायरल मेडिकेशन. 2700 मरीज थे रेमडेसिविर ग्रुप में और 2700 थे प्लेसिबो ग्रुप में जिनको रेमडेसिविर नहीं मिला. उनका एंड पॉइंट था 28 दिन पे कितनी मोर्टिलिटी, और ये सब एडमिटेड पेशेंट्स में हुआ. और उसमें जो कंक्लूजन दिया उस स्टडी का WHO ने नवंबर 2020 में कि रेमडेसिविर ग्रुप में और जिसको नहीं मिला उसमें कोई मृत्यु दर में फर्क नहीं था. 300 मरीज उसमें मृत्यु हुई रेमडेसिविर में, 300 प्लेसिबो में हुई. दूसरा, वेंटिलेटर पे जाने की प्रक्रिया किसी में कम नहीं हुई, दोनों ग्रुप्स में बराबर रही. तीसरा, ICU स्टे, हॉस्पिटल स्टे भी सेम रहा. तो ये जब आंकड़ा आ गया तो WHO ने रेमडेसिविर को कोविड ट्रीटमेंट प्रोटोकॉल से बाहर कर दिया और उन्होंने कहा इसको नहीं इस्तेमाल करना है. भारत में वो होती रही इस्तेमाल. अब फिजिशियंस भी पढ़ते नहीं है, क्या किया जाए, ये समस्या है हमारी. पढ़ते हैं ना गुनते हैं, कोई बताए तो सुनते नहीं है, ये भी एक बड़ी समस्या है. अच्छा, उसके बाद आप देखिए कि प्लाज्मा के बारे में भी यही हुआ, और प्लाज्मा का तो हमने भी ट्रायल कर लिया भारत में. उसमें 10,000 रोगियों पे बाहर भी ट्रायल हो गया और उसमें भी ये आ गया कि प्लाज्मा का देखिए शुरू में ही थोड़ा उपयोग हो सकता है जब वायरस ने अटैक किया है, क्योंकि ये वायरस को न्यूट्रलाइज करती हैं एंटीबॉडीज, ये बीमारी को नहीं ठीक करती हैं. तो अगर शुरू में आप दे दें प्लाज्मा तो शायद, लेकिन उस समय वी वर ग्रोपिंग इन डार्क. अप्रैल 2020 में किसी को पता नहीं था, इलाज वायरस का होता कोई नहीं है, न था न है अभी फिलहाल. तो उसमें भी जब स्टडीज आ गई, अब एक तरफ हम कहते हैं कि एविडेंस बेस्ड प्रैक्टिस करो, जब एविडेंस आ गया तो उसको मानते नहीं है. तो ये हमारी समस्या है, ये एविडेंस जनरेट करने वालों की समस्या नहीं है. इसमें हमारे डॉक्टर्स भी उतनी अनभिज्ञ हैं जितना, अब अगर किसी रिश्तेदार को आप कह देंगे ये ड्रग लाओ तो वो तो दौड़ता है फिर लाने के लिए, उसे लगता है कि मेरा मरीज बचेगा नहीं अगर रेमडेसिविर नहीं मिलेगी या उसको प्लाज्मा नहीं मिलेगा. और कितने लोगों को मैंने डिस्करेज किया कि तुम डॉक्टर साहब से ये कह दो, प्रभु आप लगा सकते हैं, अपने अस्पताल से लगा दीजिए, मैं नहीं ला सकता. आपके मरीज बचना होगा तो बचेगा, नहीं बचना होगा तो ये देने से नहीं बचेगा. ये मैं बता देता हूँ, मैं कितने लोगों को डिस्करेज किया है मैंने दोनों चीजों के लिए पिछले 1 महीने में, आप समझ नहीं सकते. और ये कहना कितना मुश्किल है किसी के लिए भी कि तुम मत रहने दो, मत दो. देना तो बहुत आसान है, तो ये चीज जो है लोगों को बहुत मैच्योरली समझनी पड़ेगी, और ना तो ये इंग्लैंड के एनएचएस के प्रोटोकॉल में है दोनों दवाइयां, ना यूएसए में प्रोटोकॉल में है, ये हमें समझना पड़ेगा। तो अब ये अब समझ में आ गई है, तो अब उन्होंने गाइडलाइन में से निकाल लिया है उसको, देर आए दुरुस्त आए, ठीक है।
I think Tiwari ji,
Yeah, it's over.
time.
Question is over.
Question is over. Before I hand it over to Dr. Mahesh Verma for a summary of today's program, what I could understand that I think I would like to give 3 messages out of whatever. Of course, their messages are perhaps more and more. Number one, that today I want to give a message which perhaps the concept was started by decades ago, but our senior colleague, who is unfortunately no more, Professor Ranjit Rai Chaudhary, the eminent pharmacologist of the country, he always used to talk rational use of drug, rational use of drug. And he created a platform of rational use of drug. Dr. Sharma, you will agree with me that for medical professionals, rational use of drug is a continuous CME. It is not only one time, it is a continuous CME for their entire professional career. Number 2 is very important that we have understood certain predisposing factors. So we have to raise a red flag to those who have recovered, going back home, that you are under this red flag and you require this precautions. And number 3, that I feel that why not at the time of discharge, certain examinations are mandatory, as mentioned by Maipal and all my colleagues, that examination of the nose, examination of the oral cavity, examination of the eye. Why not? Nasal endoscopy करके देख लीजिए, उससे आपको कुछ क्लू मिल जाएगा। तो यही सब चीजें हम लोग थोड़ा सा incorporate कर लें. Today we are tackling with this so-called epidemic, increasing numbers, notifiable disease. Perhaps we will be able to have a check somewhere. And number 2, it is unfortunate that we had it in India. पूरा ग्लोब का जो मेडिकल प्रोफेशन है वो हमारी तरफ देख रहा है कि हमने कहाँ कमियां की. कुछ ना कुछ तो कमी की है हमने, या हमारे जीन्स ही डिफेक्टिव नहीं, जीन्स डिफेक्टिव नहीं है, हमें कमी. Mahesh, over to you for the final.
Thank you. I know everybody is very tired, but just give me a couple of minutes because let us refresh.
उसको सुनने के लिए कोई tired नहीं है Mahesh. Please.
Thank you, sir. So, as usual today, the show was opened by Mr. Tiwari and then took over by Dr. A.K. Agarwal. Thanked everybody, and post-COVID challenges is a big issue. And he said that the ENT has been dealing with many fungal conditions. Well, they are well tuned to treat, whether it was ear candidiasis or mucor. Certain areas in Punjab and eastern areas are very common. But for many typical fungal infections like rhinosporidosis in Orissa, there was a geographical distribution was seen, but occasional conditions has become widely prevalent today. So big challenge for patients and medical professionals. So we had, he invited Professor MC Mishra, first speaker. He felt very apt and important topic because it's being epidemic also. He was surprised many of us earlier, very rarely, but never expected such big difference between first and second wave. We knew certain cases can get opportunistic infections. Example, in kidney transplant cases, cancer therapy, bone marrow transplant cases, second wave showing large number of patients of mucor following severe sequelae of corona. Seen in home quarantine patients also. Could be uncontrolled diabetes or a steroid use. Some say mutant virus could also be there, or industrial oxygen, or cylinders used for nitrous oxide or other gases. Humidification of oxygen is also thought of. So many unexplained causes, largely cases of rhino-orbital mucor. So patient with the sinuses issues have more likely to get. So issue is large number of patients. Patients are not getting amphotericin B, which is so crucial. We have almost 9,000 patients today. The worry is invasive mucor, including eye and brain, still groping in dark. What happened exactly could also be nasopharynx hygiene or mutant virus. Need to look at it, look at the data carefully. Dr. A.K. Agarwal thanked Professor Mishra for all the inputs and then invited Dr. Padma Srivastav. She said about her opinion and stake about rhino-orbito involving brain, why sudden deluge of cases in second wave. Today, to keep up, let's not color code the patient, please. It is black because necrosis it brings about. 2019 study compared cases in India with rest of the world, and South Asia had only about 0.43 per 100,000 cases. Of course, we had a little more than that in India. The commonest is rhizopus. The most malignant is Cunningales. So cases more than 9,000 today. 60% cases are of ROCOM. Known to be Mucor emboli, where mucor causing embolism through the sinuses extends to basal ganglia of brain, sometimes causes granuloma, which is better than abscesses. Angioinvasion and involves cavernous sinus and thrombosis and causes hemorrhagic conditions. 75% of mortality in cerebellar cases and also seen early. Need to bring it down lower to 35 to 40%. Morbidity of ROCOM is focal deficits, seizures, new onset of headaches, encephalitis. It quickly goes to second size also. The spectrum of ROCOM is being assessed. It is more ROCOM than rhino-orbital. Why this surge? There's a big hypothesis. It could be misuse of steroids because these are over-the-counter available, diabetes, COVID, low immune problems, because lymphopenia affects pancreatic islet cells, so causing diabetes. Patients think steroids are Ramban, like peppermint. Other could be rampant use of steam inhalers, steam inhalation, breach in mucosa, saprophytic fungus, mucorales can get in. So nasal hygiene, zinc, there is no evidence. Treatment is no difficult, no different COVID or non-COVID, only early diagnosis, get KOH mounts, red flag it, blood PCR may help, biopsy every time, not possible. So then she also said the number of cases is mostly rhino-orbital or rhino-orbital cerebral. How come it only around sinuses and not pulmonary mucor? That was a big issue. Therefore, diabetes remains one of the major factors for mucor. So, yes, therefore diabetes, sorry. Yes, then we had Dr. L.R. Sharma, Major General L.R. Sharma, Apollo consultant as a physician. What does he think? He has treated nearly 1,000 patients. The big question is why happened? Diabetes mainly could be the cause. He says we are diabetic capital, exponential increase of cases. Data also show that 95% are diabetic cases. Underlying or pre-diabetic with steroids can also cause. Irrational use of steroids also is a major factor. Management of diabetes has taken a backseat, especially patients at home. So diabetes affects all systems and hyperglycemia affects neutrophils. The fungus is ubiquitous in the environment. Only weakened immune or immunocompromised patient can happen along with contamination. Hyperglycemia affects phagocytic activity, so negatively, and promote fungal growth. Whether stem cell transplant, liver transplant, HIV patient, chronic kidney disease patient, overall in these patients, mucor cases quite high. COVID per se is also contributing, and ICMR looking at it. 75% mortality in, So the number of cases is mostly rhino-orbital and rhino-orbital cerebral. How come it is only around sinuses and not pulmonary? Big question he asked. Therefore, diabetes remains one of the major factors for mucor. These patients have high ferritin level also. Is COVID releasing iron into the system, which causing multiplication of mucor? I think that was a big question asked. Diabetic ketoacidosis patients were also prone to such infection, so susceptible would get it. Spores get through the nostrils, invade vessels, causing necrosis of tissues, and spread into the bone, sinuses, ethmoid, orbit, and beyond. We had earlier high cases of mucor, maybe geographically. Quarantine into small rooms without hygiene, humidity, etc. could also support it all. Whether nasal swabs for samples were truly sterile, he asked. Cutaneous mucor happens through contamination of wounds in immunocompetent patients. He said the holy trinity is pre-diabetic or hyperglycemia, uncontrolled diabetes, and steroids, irrational use. This is a holy trinity which is mostly causing this mucor. He said challenges to be taken by multi-specialty team. Fungal infections are, so it's a double whammy, he says. There are more cases and no drugs. Dr. A.K. Agarwal, it was eye symptoms which alerted patients for experts. Then he invited Dr. Mahipal Sachdev, but then Dr. Shishir Narayan, who is a retina expert, he shared his presentation. He said after first wave, there were a large number of eye cases, but after the end of the first wave and beginning of the second wave, a lot of cases of fungal infection, rhino-orbital mycorrhizasis. Second wave, epidemic of mucor, locally invasive destructive fungal infection of orbital adexia. Many factors could be anotypical, micro, or gross. Dr. Mahipal Sachdev talked about ROCM. He says it's a notified disease today. Why does mucor inhabit the viral land? Because there is decrease in number of lymphocytes in body. There are comorbidities, pulmonary functions is decompensated, immunosuppressive therapy, hygiene of oxygen concentrator or bottles. So viral infections are also bringing down severe immunity. So fungal infections are increasing because the disease profile and immunosuppressives. These fungal infections have high mortality rate. Mucorales are commensals everywhere. And other causes could be diabetes, steroids, tocilizumab, elderly, severe infection of COVID, the double mutant, which is a could be a pot boiler, mechanical ventilation, supplemental oxygen, but something more has happened in young and non-infected patients. Why is happening there? So there is something more than that. Studies show that 95% were diabetic with poor glycemic control. So triage, risk, and stage, and early treat. That is the mantra. Pathogens can enter either through ingestion or inhalation or through trauma, and it can bring about angio invasion, vessel thrombosis, and tissue necrosis. So the stage 1 is a nasal involvement, stage 2 is a paranasal sinuses, stage 3 is involvement of orbit, and may ultimately need exenteration, and stage 4 is CNS gets involved, so mortality is 30 to 50%. Sportive treatment is utmost important. Can we prevent it all? He said, finally, yes, by judicious use of drugs, diabetes to be given aggressively managed, aseptic condition in oxygen management, personal hygiene, betadine goggles, prophylactic posaconazole in high-risk patients. No long-term steroids, and we must taper it quickly. Incidences 1 in 1,000 in admitted patients, and 2 in 10,000 in all the PCR COVID positive. So sum up, moderation of drugs, awareness, and consult. That was his final point. So panic need to be suppressed. Then Dr. A.K. Agarwal, so let us take all these steps which has been highlighted by Dr. Sachdev. Then I came, Dr. Mahesh Verma, I described about dental part, red flags, management, rehabilitation. Dr. A.K. Agarwal invited Professor Sunil Agar regarding policy and public health aspect. Sunil Agar, 10th March, we had only 1 crore 20 lakh cases, and on 24th of May, there are 139% increase of cases. We need to deep look down, increase number of cases in different states, and 718 districts. NCDs are everywhere. What is special in South Asia region, especially in India? Under Ayushman Bharat, we have 1.5 lakh health and wellness centers. We have 130 crore population. We need guidelines for all the levels of healthcare, district level, community level, panchayat level, and down below. We need standardized guidelines for community health workers and put the message across. It also has mental health issues. Do's and don'ts messages to be flashed through mass media, as it is a notifiable disease, being mandatory and obligatory part of each doctor. Dr. A.K. Agarwal, what are we facing is undesirable. We need to manage it well. Entire world is watching us. Dr. Girdhar Gyani, happy to find blend of all the experts at this forum, which is very rare. He said wave 2 had experience of wave 1, but was wanting. Why this malady only in India and post-COVID? Then it must be difficult to find answer. Dr. A.K. Agarwal, we really need to understand and analyze jointly with public health. Dr. Sunila Garg, we need to look at the science behind the whole thing. In second wave, Second World War, and in Spanish flu, time studies were only observational. These were not scientific. We need to study cases developed versus non-developed. Dr. M.C. Mishra, whether any instrument has been readied by ICMR task force, which is to be filled by each patient, need to do it urgently. Then only we can get to the bottom of the issue, as there are nearly 9,000 patients. Need good publication and also need to publish enough urgently. Many may not survive. Whether remdesivir was used indiscriminately is also one of the possible causes. Dr. Sunila, when we don't have much prevalence of NDCs in rural areas, Dr. A.K. Agarwal, we all need to write to DG ICMR. Dr. Vijay Agarwal, President Kaho, informative session. What is purpose of is a disease notifier, and if we don't gather data, what is the use? And make it public without identification. Required for groping answers. Let us write to Niti Aayog and other authorities. Need extensive survey for it. Dr. A.K. Agarwal, registry has to be so extensive. Dr. M.C. Mishra, make a Google Performa and send it to all the hospitals, which is not difficult. Dr. Mahipal, Ophthalmic Society shall ready the form soon, and it will be shared to everybody. Dr. Vijay Agarwal, need to take help of epidemiologists in framing it. Dr. Sunila, it has to be holistic for all. Dr. A.K. Agarwal requested Dr. Sunila to get it done. Then we had a couple of question answers, and finally, we had Dr. A.K. Agarwal giving us 3 messages. Number 1, rational use of drugs. That it has to be continued CME, as it was always advocated by Dr. Ranjit Roy Chaudhary. The second is understand predisposing factors. Raise the red flags wherever it is there. And thirdly, at discharge, certain examinations, certain tests that must be mandatory, done, undertaken, and advised. Thank you very much.
Thanks a lot to all of you, sir. I'm very grateful to
over to Tiwari ji.
Thank you, sir. Thank you very much.
We have finished it, and back to you.
Thank you, sir.
I want to thank all my experts.
Yes, sir. Thanks a lot.
Thank you, sir.
Welcome. Warm welcome. Thank you, sir.
Thank you, sir. Thank you, sir. It was really good.
Thank you, sir.
Thank you, sir. Thank you.
Namaskar. Thanks a lot, sir.
Thank you.
Bye for now.
Bye.
Krishna
Bye.
ji, Mahesh.
Sir, thank you, sir.
Bye.
लंबा हो गया सर, बहुत लंबा हो गया सर.
शुरुआत में टाइमिंग में थोड़ा सा हो जाता है.
आगे से 1.5 घंटे का करना चाहिए सर.
2.5 घंटे बहुत लंबा.
वेरी टाइम.
ये तो
सर
रिकॉर्ड हुआ है, इसको उस पर डलवा दीजिएगा.
सर वो डल जाएगा, अभी डल जाएगा.
पॉपुलर का इतना ज्यादा अच्छा प्रेजेंटेशन था और सबका ही था, बहुत अच्छा.
थैंक यू सर.
सर आपका तो